Okay, as Ian said, I did talk previously on specifically, did James III have porphyria or not? And really summarising the previous talk very briefly, mother and son psychiatrists, Hunter and McAlpine, claimed that George III had acute porphyria, acute intermittent porphyria, and they later changed the diagnosis to the rarer, about a third less common, and porphyria itself is a pretty rare disease, and it's a much milder condition, much less likely to have psychiatric or toxic confusional complications. I, over a period of time, re-examine all the medical records. The thing about George III is there's 100 volumes of medical records in various sites, and I went through this, and as I mentioned last time, showed that they were highly selective, economical with the truth, I think is the term, and they clearly were wrong with their claim. And a re-evaluation of the records, and did this with Alan Beveridge from Fife, and I think we clearly showed that he didn't have porphyria and he had recurrent attacks of acute mania. And I thought, well, that's it, go on and do something different, something more useful perhaps. But the historians have said, well, that's all right, you know, we don't think George III had the condition, but what about James VI, what about Queen Victoria, the Duke of Kent, and all these other people that they claimed had porphyria? Well, it seemed to me that if George didn't have it, it was a pointless exercise and very unlikely that anybody else had it. But that wasn't good enough for the historians. They say, you know, who are you against Dame Lady Antonia Fraser? So for this reason, I've actually carried on and looked at some other members. Before I move on to other members, I thought I'd just show you some recent stuff that Alan and I did, which sort of sets a bit of a sub-theme for the talk. I'm very keen to move away from this is my opinion, that's your opinion, well, let's just sort of toss it in the air. Can we be more objective and more, as it were, scientific in our historical diagnosis? And this is an attempt to look at George's 3 episodes, 1788, 1801, and the final episode, 1810, 1811, using a tool. And this is the OPCRIT tool that Peter McGuffin developed, specifically for looking at psychiatric patients. And I actually gave a talk at the College of Psychiatrists, and I was rather nervous again because he was in the audience, but he was actually rather flattered. He said, this tool was developed for looking at case notes. We didn't think it would be used for case notes 200 years old, but at least he was, and this is what you put into the computer program, the various signs and symptoms of the patient, you press a button, and it comes up with the suggested diagnosis with the various criteria, DSM-3, various possibilities, ICD-10, RDC, and you can see that for each of the episodes we're coming up with acute mania plus or minus psychosis, and interestingly in the final episode before he developed probably a form of dementia at the age of 70 when the Regency was established, if anything psychiatrically the mania was rather minor, less severe as hypermania. And this is a theme I want to try and develop. Let's get away from this is my opinion. We need to be much more objective in historical diagnosis. The other thing we can do is to try to quantitate the severity of mania. And again, this is the Young Mania Scale. It was actually Tim Crowe, who I'm sure will remember, suggested this was worth an attempt. And what we've done here is, unfortunately, there was not, he wasn't looked at during this 1788-89 episode by a single observer, so we've had to sort of pool the results, initially from George Baker, then his equerry, Robert Grenville, and finally the psychiatrists, or what they called at that time the mad doctors, the Willis family, and produced a sort of aggregate score, and you can see he reaches a scale of about 40. This is the severity scale, and a figure of 40 is definitely, in the peak of the episode, a grade 4 acute mania. Again, we try whenever possible now to use these scales, and I'll mention some of it a bit later. Well, briefly, the tree, and these are some of the people. So here's George, and we're going to look at his grandson, August Esther, who was the son, so-called illegitimate son, of the Duke of Sussex. And I say we've only looked at individuals where there is good clinical data, not just odd letters and hints, but where there is good sort of observation. So I've looked at Augustus, the nature of his condition. He was claimed to have porphyria, and you can see that there's a gap of 5 generations when we come back to James VI. And again, there is good data, clinical information on James VI, so we're going to look at him as well. Anyway, let's start off with August Esther. He was the son of Prince Augustus Frederick. He was the 6th son of George III. He had actually recurrent attacks of asthma in early life, in childhood, adolescence, and 20s and 30s, and spent most of his time on the continent. And while he was on the continent, he met Augusta Murray, married in Italy, and actually had 2 children, a son and a daughter. This infuriated George III because he wanted to, the Royal Marriages Act, he wanted to dictate who all his children married, and he managed, he claimed, to get the wedding annulled, and this obviously caused a lot of angst for various members of the family. Anyway, at the age of 28, Augustus developed a sort of relapsing, progressive neurological condition, visual disturbance, paraplegia, impotence, but no cerebellar signs. And this, as we'll see, has been claimed to be the first recorded case of multiple sclerosis. Now, Hunter and McAlpine claimed that the multiple sclerosis was atypical, and you can see there are no real cerebellar signs. So from ordinary textbooks, there is an atypicality, but they have said that the atypicality confirms that in fact he had porphyria. You know, leaping where angels dare to tread. Well, let's look at it in more detail. So the differential diagnosis, I say, most of the history textbooks and most books do say this is the first recorded case of multiple sclerosis. The data is really quite extensive, because from the age of 20 to the age of nearly 50, he kept a very detailed diary in which he wrote down his symptomatology, the doctors he saw, their advice and their diagnosis. So there's good information, and he obviously was quite an astute observer. So, I say, most of the textbooks would say that he had multiple sclerosis. However, there are atypical features, I think, suggests a condition, Devick's disease, or neuromyelitis optica, which for many years was thought just to be a variant of multiple sclerosis. But as we'll hear, it's a specific disease in its own right. And of course, Hunter and McAlpine said this atypicality was in fact the neurological manifestations of variegate porphyria, and if the grandson had it, that confirmed that dear George had it. So we've used this neurological database, this computer program. It's called SimulConsult, developed by Michael Siegel in the States. It's a neurological database which provides a weighted differential diagnosis. It compares, you put in the patient's symptoms. I say it's all been used up till date on sort of living patients. It's used as a diagnostic aid, and it compares the patient's symptoms with a database of about 2,500 neurological syndromes. And Michael claims it involves cognitive errors and helps make the diagnosis more accurate and, being Americans, much more cost effective. As we see, it gives you a differential diagnosis, and in fact you can link the differential diagnosis to, or adjust the differential diagnosis by the relative incidence of the disease, and we'll see this with Augustus. And that's a reference if anybody's interested. It is available. You just need to sign on, log on, and you can download this. And it's quite interesting. If you talk to the neurologists, the young school of neurologists use it, but the old school neurologists say they don't need to. It's all up here, you see. But you know, we thought it would be useful to try this in this. So this is what we put in. We put in 53-year-old male, no family history of similar illnesses. He had urinary symptoms, visual impairment, gait disturbance, hyperalgesia, particularly a sort of paraplegic type symptom. He complains particularly an episode of recurrent impotence, but no dysarthria, no tremor, no ataxia. He had recurrent exacerbations, and the question is, what's the differential diagnosis for this clinical syndrome? And I'm sure you'll all know the answer. And if you do this, you come up with number one diagnosis of Devick's disease or neuromyelitis optica, and the second diagnosis is multiple sclerosis. We now know that, I say, when I was a student in St Andrews, it was a form of multiple sclerosis, or a particularly different variant. We now know it's a completely different disorder, sort of an autoimmune disease in which an antibody is formed against aquaporin 4, which interferes with blood-brain barrier sort of function. So it's quite a distinct disease. But it's a much rarer disease. About 5% of patients with so-called multiple sclerosis have actually this condition. So we can actually put this relative incidence in, and if you do that, as you might expect, multiple sclerosis comes up as the number one diagnosis, with Devick's disease as number two diagnosis. So you can certainly in practice put in the relative incidence of the condition. I think it's a little bit artificial, but it does indicate how it is particularly used. The important thing to note is that variegate porphyria is nowhere. Down here, somewhere down towards 2,500. Acute intermittent porphyria is sort of mentioned, but you can see the relative probability is pretty negligible, and these are the other conditions that in the batting order, but I say it goes down to about 2,500. So summarising then, I think this is the first use of the SimulConsult programme to look at the differential diagnosis of a historical figure. So it's used increasingly in clinical neurological practice, and comes up with Devick's disease or neuromyelitis optica and multiple sclerosis as the most likely diagnoses. And the probability in any particular population obviously is partially reflected by the relative frequency, the fact that multiple sclerosis is probably 20 times or so more common than Devick's disease. But the important thing from my point of view, the object of the exercise, is that variegate porphyria, which is what Hunter and McAlpine claimed Augustus had, is pretty well excluded. Right, now I'd like to move on to James VI. So this is largely, I think, for my benefit, actually. I'm sure everybody knows this and will be able to correct any errors in it. The sort of major features. Mary, Queen of Scots, obviously was his mother, and people claim that she had the problem. Very dysfunctional childhood in the first couple of years. Crowned King of Scotland at 13 months. A series of regencies, educated by the provost principal of St Andrews at the time, who gave him a fairly rough time. Obviously the execution of his mother and the sort of his attitude to it. I mean, I'm sure the psychiatrists will be very interested in the accounts of his attitude to the question of his mother's execution, and the relationship between her execution and his cited aim, which was to succeed Queen Elizabeth. He marries 5 children, 3 of whom reach adulthood. It's obviously important if we come to look at the genetics of the condition. He succeeds Queen Elizabeth, fairly straightforward, involved very much in the gunpowder plot one way or another. Tragic death of his eldest son Henry, probably of typhoid, death of his wife. Each of these events triggered a relapse in his symptomatology. We're able to study him, although we're talking 200 or 300 years ago, because there is a fantastic medical report by his physician Theodore de Mayerne, and I'll say a little bit about him. And he dies in 1625, and because it was believed that he was poisoned, a post-mortem was performed, so we do have some additional information. one or two pictures. This is a picture of him as a child, rather pale, delicate skin that Damley comments on. The paediatricians have commented on his fingers as a sort of possible fusion of two of the digits, but I've never seen any mention of that. But and painting hands is really quite difficult, so I don't know. But certainly some people have used the portraits in their differential diagnosis. Here's the last portrait of him before he moved to England, a rather, I have to say, rather shady-looking character, but you know. And this is Theodore de Mayenne, who was an interesting chap. He was a Swiss Huguenot physician, trained in, came from Switzerland, trained in Germany and in Paris, in Montpellier. Because he was not Catholic, he sort of left France and came to England, and he was obviously a very able person. He set up the Society of Apothecaries. He set up the first pharmacopoeia in the Royal College of Physicians. Really very able, and the quality of his clinical papers and clinical reports are fantastic, and we're very much indebted to him. And he wrote in 1623, just 2 or 3 years before George III died, a medical report. And he wrote this report because he was summoned back to Switzerland on family business, and he didn't have very much opinion of the sort of the local British chaps, and so he wrote this medical report with advice what to do while I'm away. Unfortunately, he was away for quite a long period of time, and the king fell ill, and the doctors totally ignored all the advice, and poor old James died. I'm not sure of the cause and effect relationship. But he wrote this many-paged report, and it's in the British Library in Sloane manuscripts, and written in Latin. Now, interestingly, Michael Moore, in about 1895, translated this report, but only partially, and I can't understand that. He said, I'm giving you a partial translation of this medical report to give you a sort of feeling of it, as a sort of the sense of what the report is like. And everybody's used this partial translation. And it seemed to me that, you know, you've got to get all the data. You can't just sort of be selective. And fortunately, a couple of colleagues, Terry Hunt, and was able to complete the translation. So we actually have a full translation, filling in a few relatively minor gaps, but nevertheless was important. So we do actually have a full account of the report. Well, what do we get from the medical history? Well, this is trying to summarise, I say, 20, 30 pages of Latin text. As I mentioned, very much a dysfunctional childhood. You can imagine the social workers would be all over him these days. Between the ages, delayed walking, he was unable to walk properly until probably between the age of 5 and 7, and there was persistent weakness, difficulty in walking in a peculiar gait for the rest of his life. There were various movement, dystonias, etc., movement behaviour disorders, comments that his tongue was too large for his mouth, difficulty in speaking, difficulty in swallowing. Describes that he actually ate his drink, which is quite interesting. Now, when I discussed this with a distinguished historian, she said the speech difficulties was that he talked in broad Scots and nobody could understand it in England, but I wouldn't like to comment on that one. But certainly there are, orofacial issues to be considered. He had recurrent episodes of renal colic, and he describes this is again de Mayenne, describes the passage of urinary calculi as a bloody red crumbly sand, and I think this tells us something about the nature of the renal stones. They weren't large single calcium whitish stones. They were described as red, crumbly, yellowy, crumbly, sand-like material. And he clearly has episodes of urinary tract infection, describes this in great detail. He says gouty arthritis. Now, gout in those days meant many things, but he describes in particular the gout of the big toe of his left foot, difficult in walking. We've commented already on the skin. a very scanty beard, which I think may come relevant later, recurrent episodes of diarrhea. Again, this very unlike porphyria. Patients with porphyria, they don't have diarrhea. Hemorrhoids. I think he misused alcohol, and that may contribute to help in the diagnosis. Possibly, I think a recent book in the States, Michael Young would say probably bisexual. Significance not terribly clear, but interesting. Damley comments that he was prone to hypochondriac melancholy, whatever that is, and certainly from between 1619 and 1625 there was a progressive intellectual impairment. There's been quite a good study by Holmes and Williams in the States where they analysed his letters using techniques we call cognitive archaeology, where you can actually look at people's texts and actually show an intellectual deterioration when you look at the vocabulary, the complexity of the sentences, etc., etc. And somebody's done this with the letters over his life, and in particular from about 1620 to 25, there clearly is good evidence of intellectual impairment. Well, what people have suggested? Well, the first suggestion was that he had rickets. This was the cause of his weakness and the difficulty in walking, due to Helen Littell, his wet nurse who looked after him for the first year of life, was said to be an alcoholic. And I say variegate porphyria is what McAlpine put forward, and I say many other people are repeating this repeatedly. Beasley in New Zealand suggested that as well as porphyria, he had evidence of cerebral palsy and caused the weakness. Holmes, a retired physician in the States, suggested he had a hereditary neuromuscular disorder because there was some evidence that Charles, for example, was a late walker, and he suggested Charcot-Marie-Tooth, but this doesn't explain many of the other issues. Discussed this with a dental colleague, and pleased to see there's a dentist in the audience, so she might have some comments on this. There's a fantastic book, Gorin's books, of oral cleft defects and large numbers of syndromes of the head and neck, and he came up with this as a possibility. But again, it only partially describes some of the symptomatology, not the whole picture. So SimulConsult came to our aid at this point, and we put in just the basic information. Here we have a 59-year-old male. We're talking about when he was under the care of Saul de Mayen in 1619. Motor development delay, which was present, difficulty walking ever really since childhood, renal stones, which really became a significant problem from the age of 40. He had abnormal speech, but the onset, it was present, but onset. So a fairly broad net was used. So we put this into the computer and pressed the button, and obviously I was looking for porphyria, and nowhere are any of the porphyrias. I thought, well, that's fine, we can go home now. But up came this diagnosis of Lesch-Nyhan disease. Now, Lesch-Nyhan disease is a pretty rare genetic defect. When I was with the MRC at Northwick Park, Richard Watts had about half a dozen cases of this disorder, Lesch-Nyhan syndrome.
About 20, actually.
All right, sorry, 20. I knew there was. Well, you probably know more about it than me. But he had people with what's called the severe neurological picture, and it was a really pretty nasty condition with a lot of dystonia, with self-mutilation, and a really disturbing problem. Although interestingly, Nyhan, who with Lesch reported the case initially, commented that if you went in the old days when mentally retarded, handicapped children were in institutions, you could pick up the children because they actually looked brighter than the average Downs or other syndromes. That's what he says, I don't know. But I'd only ever seen this condition, but more recently people have shown there is a spectrum ranging from the severe form of Lesch-Nyhan syndrome to patients purely with hyperuricemia and renal stones without any neurological problems. And you can see the most likely diagnosis is this mild neurological form of Lesch-Nyhan syndrome. I'd say I was particularly obviously concerned, interested in the fact that nowhere do any of the porphyrias come. But I thought it was interesting to say, well, you know, I was rather biased because having only seen in Dickie Watts's department this severe case, what about this milder form? Well, the person who's the authority at present is Haider Jinner in Atlanta, and he has studied large numbers of cases, and if anyone's interested, I can give you a reference. He's got a report of about 75 cases of what he calls attenuated or mild Lesch-Nyhan disease. It basically is a very form thrust of the full syndrome. There certainly is no self-mutilation. There may be sort of mental handicap, IQ 70, 80, but there are cases of this attenuated form with undoubtedly has the disorder, but with IQs, normal IQs, and even IQs, I think the highest IQ is about 140. So having this syndrome doesn't indicate that you've got evidence of mental retardation. A little bit about it. It's an X-linked disorder and a partial deficiency of this enzyme, one of the purine salvage pathways enzymes, explains the increased amount of uric acid in the urine. And there's a bit of evidence that you can classify the patients on the amount of activity remaining. So patients with the full-blown syndrome will have less than 1% of the normal activity in their lymphocytes, etc. Patients between 2 and 5% will have the mild form, and patients with about 10% or above may only have the renal stones. And in fact, there have been so-called normal individuals who've been identified who have reduced enzyme activity, only about 50% reduction, who, to all intents and purposes, are absolutely normal. So there's a range of enzyme activity, residual activity, and there's a range of severity. Variable motor disabilities. They may or may not have cognitive impairment, but interestingly, and I sort of became interested in this point, they frequently have what he describes as socially difficult behaviour. Another term that he used, if I can remember, in Jenner's book was he talked about they were maladaptive. He used the term that these patients with this attenuated form were maladaptive, and they had poor attention, impulsivity, poor judgment, and some of them went on to have, as we'll see, part of the autistic spectrum. And we're coming round to, does this explain some of the features of James? I'm not saying that he absolutely did have this condition, but this is the sort of the number one differential diagnosis that comes up, certainly on the evidence that we have. This is the neurological and you might say psychological problems. They all have hyperuricemia with gout, which James had, renal stones, and it's always present if untreated. And I think, and colleagues may disagree or otherwise, that the sort of red, sandy nature of the gravel that was produced, rather than the single renal calculus, is consistent with uric acid stones. Well, as I say, there is certainly evidence that the attenuated form is associated with autistic features, part of the autistic spectrum disorder. As far as I can see, psychiatrists every now and then have or child psychiatrists every now and then have a sort of party, and they reclassify, which is perhaps very helpful for them, but rather confusing for others. I think if you use DSM-4, that James meets the criteria for Asperger's syndrome. And if you use the adult Asperger assessment score of Baron Cohen, and it's a bit controversial, he does score in the Asperger range. This is the data from Baron Cohen's paper. Control scoring about 5, standard deviation of 2.5. Patients with full-blown Asperger's 15 plus or minus 2. James scores 12, and the cutoff is about 10. So he would be consistent with a mild form of Asperger's. So then, in summary, we've reviewed the medical history of James, and again, this novel use of this diagnostic implement, SimulConsult, used for historical neurological conditions. Again, reiterating, perhaps ad nauseum, rejecting a diagnosis of porphyria, and surprisingly, and it really shook me when it came up on that, suggesting an attenuated form of Lesch-Nyhan disease or Lesch-Nyhan syndrome, and he does have some features, I think, consistent with Asperger's. And finally, just like to acknowledge Alan Beveridge, who many of you I'm sure know, was very helpful with me in using the OPCRIT analysis. Peter Garrard, a neurologist at St George's, who actually first suggested using SimulConsult. Julian, a historian, who has been very helpful in guiding me to some of the literature and some of the original primary stuff to read. Terry Hunt did the objectively did a read of the Latin report by Damley, and John Stevenson, who's I think paediatric neurologist in Glasgow, he also was very helpful with the SimulConsult, because I think it was important that it should be done somewhat objectively, not by myself, with a preconceived idea, particularly looking at est, and it's very, very useful to have the help of these various colleagues. Okay, thank you very much indeed. Thank you for your attention.